Hey guys, in this video we are going to cover flowcharts and tables from the topic of NSTEMI, that is non-ST elevation myocardial infarction. So starting with table 1, TIMI risk score for NSTEMI ACS. Here TIMI refers to thrombolysis in myocardial infarction, and this risk score tells us about the 14 days of death, new or recurrent myocardial infarction, or severe recurrent ischemia which is requiring urgent revascularization. And this risk score contains 7 markers, and they are age more than or equal to 65 years, or coronary artery disease where the stenosis in the coronary artery is more than or equal to 50%, or there could be deviation of ST deviation of more than 0.5 mm on the presenting ECG, or the patient might be having raised cardiac biomarkers, or there could be more than or equal to 2 original episodes within 24 hours, or there could be any previous history of angina, or the patient could be having more than or equal to 3 coronary artery disease risk factors. And the maximum score that the patient could have is 7. And for this maximum score, the adverse event incidence could be around 40%. In this table, you do not need to remember all this percentage. Okay. Now coming to angina equivalent. This angina equivalent refers to symptoms other than the chest pain. So there is certain population like the elderly, patient with diabetes, in female patient, and patient having multiple comorbidities like CKD. So in these patients, the patient could be having myocardial infarction, but they generally present to the emergency not with the symptom of chest pain. They could present to us with symptoms like dyspnea, epigastric discomfort, nausea, weakness, or diaphoresis. These are very important factors which can tell us that the patient is having myocardial infarction. And this is a common question which is asked in the Viva as well as in the NEET examination. Now, coming to approach to a patient with acute chest pain. So, obviously, the first step would be to get an ECG done. So in the ECG, you can easily tell whether the patient is having STEMI or not. If the patient is having ST elevation myocardial infarction, then you have to follow that particular flow chart where you can either go for reperfusion or primary coronary intervention. Then, if the patient is not having STEMI, then there are two possibilities whether the ECG changes are ischemic or non ischemic. And if the ECG changes are ischemic, it means you have to know the initial troponin. And if the initial troponin is less than 99 percentile, then you can go for observation as well as admission. Then, in the non ischemic changes, you should know whether the patient is having any known coronary artery disease. And if the patient is having coronary artery disease, so in that the ECG is not reliable because there could be some other underlying baseline of ECG changes. So, that is why you should focus on the initial troponin level. And in them also, if the initial troponin level is less than 99 percentile, there you should choose for admission and observation more than discharge. And apart from that, if there is no any known CAD, okay, then you should see the hard score. Hard score refers to history, then ECG changes, then age, any risk factor, or troponin value. So if the hard score is in between 0 to 3, then you can just go for serial troponins if there is high index of suspicion. And if all the serial troponin values are less than 99 centile, then you can safely discharge the patient. But if not, and if these values are more than 99 centile, it means you should definitely call the cardiologist and get an opinion done. And in both the ischemic changes as well as higher heart score, there you should get the stress testing done or angiography done to know if there is any lesion which could be treated at this point of time. Now coming to the reasons, table 2, which is reasons for elevation of cardiac troponin values. So first of all, the most common one, that is myocardial injury related to acute myocardial infarction, and it is mostly because of atherosclerotic plaque which has got ruptured, and it is leading to thrombus. Right. The other thing could be myocardial injury related to acute MI. Here, I is ischemia, not infarction. And this ischemia is because of oxygen and demand mismatch. Like there could be reduced myocardial perfusion, which could be because of coronary artery spasm, like Prince metal angina, or it could be because of coronary embolism, coronary artery dissection, sustained bradyarrhythmia, hypotension or shock, because of which the myocardium is not getting enough blood supply, or it could be because of respiratory failure or severe anemia. So all these causes are the examples of type 2 myocardial ischemia. Then there could be increased in the myocardial oxygen demand, like the patient is having sustained tachyarrhythmia or there is severe hypertension. Or there could be other causes of myocardial injury, like the cardiac condition, which include heart failure, myocarditis, cardiomyopathy, Takotsubo syndrome, recent coronary revascularization, or cardiac procedure other than revascularization, catheter ablation, defibrillator shocks, or cardiac contusion, just like in any accident as well, or systemic conditions. So these are the conditions which you are going to come across very often in your emergency or ICU postings also, like the patients with sepsis or CKD. In them, the troponin value is always high, but in them you should do the serial monitoring of the troponin. So sepsis, CKD, stroke or subarachnoid hemorrhage. In stroke and SAH, their ECG changes also mimic that of STEMI and NSTEMI. So in them, you should very careful see the symptoms as well as the signs, because if in those patient you do thrombolysis, it is going to be very fatal for that patient. Or other causes could be pulmonary embolism, infiltrative diseases like amyloidosis, sarcoidosis, or chemotherapeutic agents, or critical illness or strenuous exercise as well. Now, coming to table 3, that is recommendations for anti ischemic drugs in acute phase of NSTEMI ACS. So, here you should only focus on the contraindication, that is, only this part of the table, the contraindication, when to avoid this drug. So, first anti-anginal drug is nitrate. It is commonly used sublingually. So, you should never give nitrates in the patients who have recently used phosphodiesterase 5 inhibitor like the sildenafil or tadalafil. So, if the patient has taken sildenafil within 24 hours, you should avoid nitrates, or tadalafil if has been taken in 48 hours, you should avoid nitrates, because the patient might develop severe hypotension in that case. And also in the patients who have a right ventricular infarct, you should avoid nitrates, because in RV infarct, this commonly leads to hypotension. So in those patients, you should first give fluids like NS, 1 pint of NS, and you should avoid nitrates. And also in the patient of severe aortic stenosis, this was asked in the examination. Severe aortic stenosis, nitrates should be avoided. Then beta blockers. So at what level of PR interval it should be avoided? So this is 0.24 second. Then other patients who are having AV block or bradycardia, like the heart rate of less than 50 beats per second, or systolic blood pressure of less than 90, or the patient in shock or Phillips class 3 or 4, or severe reactive airway disease, because this will lead to bronchospasm. So in these cases, beta blockers should be avoided. Now, talking about calcium channel blockers. Calcium channel blockers are avoided in systolic blood pressure of less than 90, or pulmonary edema, or left ventricular dysfunction. So, you should remember that in any patient who is having LV dysfunction or less ejection fraction, in that patient's calcium channel blockers like verapamil or diltiazem should be avoided. And always avoid short acting calcium channel blockers, because it can lead to reactive tachycardia, which can further worsen the angina pain. Then morphine and other narcotic agents. So these also have some slight cholinergic activity, and that is why you should try to avoid it in patients with hypotension, and this can also lead to depression of the brain center. So avoid in respiratory depression, and also avoid in patients with confusion or obtundation. Now, the clinical use of antithrombotic therapy. So here, for most of the drugs, doses is not required. Okay, only remember for aspi, clopi, and ticagrelor. Okay, so in our emergency also, we used to keep packets of aspirin, clopi, and atorvastatin. So aspirin loading dose is 300 mg, clopidogrel is 300 mg, and atorvastatin is 80 mg. So this we used to keep in the packet, and if any patient come to us with this STEMI, we used to give the cocktail of aspiclopi and atorvas. And followed by, after giving the loading dose, the patient will be receiving 75 mg of aspi, 75 mg of clopi, and 80 or 40 mg of atorvastatin. And if the patient is planned for stenting, in that patient, the clopi dose becomes 600 mg. And in that kind of patients, ticagrelor is preferred, where the loading dose is 180 mg and followed by 90 mg per daily dose. And in stenting patient also, prasugrel could be used, where pre-PCI loading dose is 60 mg followed by 10 mg per day. And the other agents which could be used IV are cangrelor, eptifibatide, and tirofiban. So in these agents, the only question could be whether this can be given oral or IV. Dose per se won't be asked. Now coming to anticoagulants. So first, parenteral anticoagulants. It includes unfractionated heparin, enoxaparin, bivalirudin, and fondaparinux. So LMWH is commonly preferred, and UFH is commonly not preferred in our hospitals also. And oral anticoagulants are vitamin K antagonist like the warfarin, or you can also use apixaban, dabigatran, edoxaban, and rivaroxaban, of which the commonly used ones are apixaban, dabigatran, and rivaroxaban. Apixaban is given in the maintenance dose of 5 mg, and it can be reduced to 2.5 mg if there is patient having CKD. Okay, or dabigatran, the dose is 150 mg and it is reduced to 110 mg in patients with age more than or equal to 75 to 80 years or weight less than 60 kg. Then rivaroxaban, the maintenance dose is 20 mg. Now, coming to the selection timing and staging of patients with NSTEMI. So first of all, if the patient is not having any high risk, okay, then the invasive criteria depends based upon the patient's preference and the clinical condition. Then the patient with very high risk, then these patients are the ones where the patient is unstable. Okay, unstable in the sense the patient is having cardiogenic shock and he might be requiring inotrope support, or the patient might be having acute heart failure with ongoing ischemia, or patient developed cardiac arrest post presentation, or life threatening arrhythmias, or mechanical complication like tamponade or free wall rupture, or angina refractory to medical treatment, or recurrent dynamic ischemic changes in the ECG. So these are the examples which you might forget, so remember them. So in this condition, you should go for immediate invasive procedure, that is within 2 hours you should get the PCI done. Okay, and then the other thing is high risk. In high risk condition, the patient is not unstable, the patient here is stable. Okay, so this could be confirmed NSTEMI or gray score of more than 140. Okay, this you should remember. Or there is transient ST elevation or dynamic ST or T wave changes. In this you should go for early invasive percutaneous coronary intervention. So, in both of these cases, you should first find the culprit lesion. That is the lesion which is involved in this setting. So, if it is feasible, go for stenting. Otherwise, you can go for CABG also. Then, apart from that culprit lesion, there will be other lesion also. So, you have to evaluate for that non-culprit lesion. And if the patient is high risk, that is the patient is in shock, or there is severe comorbs like the patient has developed AKI, or the anatomy is not feasible, so it is better to go for staged revascularization. That is, you will not touch the other lesion at this setting. You will allow the patient to take the rest and recover till you can plan for the next setting for revascularization. Or if the patient is not having any high risk and the functional status is good, then in that single setting also you can plan to improve all the lesion, that you can stent all the lesion, or you can also plan for CABG. And after this stenting, the patient will be requiring lifelong medical management.